Welcome back, Focus Learners. Today on The Explainer, we're tackling one of the absolute highest stakes scenarios in all of medicine. We're talking about the myocardial infarction, or, a heart attack. We're going to look specifically at the crucial clinical pathways for both STEMI and NSTEMI events. So whether you're aiming to sharpen your clinical acumen for the wards, reviewing for exams, or you just want a rock-solid understanding of exactly how we diagnose and treat this life-threatening emergency, well, you're in the right place. We've got a lot of highly structured, high-yield info to get through, so let's not waste a single second.
Here's our roadmap for today. We'll start with etiology and classification, then move to clinical features and presentation. After that, we'll cover the essential diagnostic investigations and wrap it all up with reperfusion and treatment protocols.
Section 1. Etiology and classification, the underlying mechanism. So before we can fix the problem, we really have to understand the microscopic mechanism. Let's start with a clear baseline definition. When we talk about a classic type 1 myocardial infarction, we are literally talking about acute myocardial injury. This is actual necrosis, the death of heart muscle tissue. And why does it die? Well, it's because of prolonged ischemia, meaning a severe lack of blood flow and oxygen. The heart muscle is constantly working, right? So when its fuel supply is suddenly cut off, that tissue damage begins incredibly fast.
Okay, let's dive into this. When you picture a heart attack, you are almost certainly picturing a type 1 event. A massive 90% of these infarctions are caused by an atherosclerotic plaque inside the coronary artery that actually ruptures or fissures. This rupture triggers a whole cascade, forming a thrombus, a blood clot that physically blocks the artery. The remaining 10%, that's made up of type 2 and non-atherosclerotic causes.
Now, while they only make up that 10%, these other causes are absolutely critical considerations, especially on the wards. A type 2 MI happens without a plaque rupture. Instead, it's a supply and demand mismatch. Think of a patient with severe anemia, terrible hypotension, or a tachyarrhythmia where the heart is just beating so fast it demands way more oxygen than the body can actually supply. Then we have non-atherosclerotic causes, like a spontaneous coronary dissection, a rogue embolism, or a severe vasospasm. And of course, we always have to keep in mind the classic precipitants that trigger these events: sudden physical exertion, intense emotional stress, an acute systemic infection, or the use of stimulants like cocaine.
Section 2. Clinical features and presentation, recognizing the crisis.
All right, shifting gears from the microscopic cause to the macroscopic symptoms. It is incredibly dangerous to rely solely on classic symptoms. While a typical presentation involves a sudden, retrosternal crushing pain lasting more than 20 minutes that is not relieved by rest or GTN spray, what's really fascinating here is how deceptively atypical the presentation can be in women and the elderly. They might only complain of epigastric pain, overwhelming fatigue, isolated shortness of breath, or just shoulder pain. The classic radiation to the jaw or left arm? It might be entirely absent. You absolutely must maintain a high index of suspicion because an atypical presentation is still a dying heart muscle. Beyond just the patient's history, their physical signs tell a stark story of a failing mechanical pump. You'll often see extreme pallor. Depending on the autonomic response and the location of the infarct, their heart rate might be racing in tachycardia or dropping down into bradycardia. They might be hypotensive because the left ventricle is just struggling to maintain cardiac output. And listen to the lungs and check the neck. If you see an elevated jugular venous pressure, you should immediately suspect a right ventricular infarct or congestive heart failure backing blood up into the systemic system. On auscultation, an S3 or S4 gallop points to a stiff, struggling ventricle. And basilar crackles in the lungs? That indicates fluid is backing up into the pulmonary system.
Section 3. Essential diagnostic investigations, confirming the infarct. 10. I want this number burned into your memory. From the absolute second the patient arrives at the hospital doors, you have exactly 10 minutes to get an ECG performed and interpreted. 10 minutes. Everything hinges on this single test.
The ECG literally dictates our entire treatment pathway. If the artery is completely blocked, you're going to see a STEMI, an ST elevation myocardial infarction. We're looking for ST elevation of 1 millimeter or more in 2 contiguous limb leads or 2 millimeters or more in 2 contiguous chest leads. Keep an eye out for a completely new left bundle branch block or that sneaky true posterior MI, which actually shows up as ST depression in leads V1 to V3 alongside tall R waves. Conversely, if the artery is only partially occluded, we get an NSTEMI, a non-ST elevation myocardial infarction. Here, the ECG might show ST depression, T-wave inversions, or frustratingly, completely non-diagnostic changes.
So if the ECG doesn't show a clear STEMI, how do we actually prove heart muscle is dying? Well, we look for the proteins the dying cells leak into the blood. We take serial measurements of high-sensitivity troponin every 1 to 3 hours. We're looking for a dynamic rise and/or fall with at least one value exceeding the 99th percentile of the normal reference range. That kinetic curve, that is the gold standard confirmation of myocardial injury. We also rely on a chest X-ray and an echocardiogram, but not necessarily to diagnose the heart attack itself. We use the chest X-ray to urgently rule out fatal mimics like an aortic dissection or a pneumothorax, and to check for heart failure. The echo is brilliant for assessing how badly the left ventricular ejection fraction is impaired, looking for regional wall motion abnormalities. But most importantly, the echo rules out catastrophic mechanical complications like a ventricular septal defect, cardiac tamponade, or a ruptured papillary muscle.
So imagine you're in the ER. The 10 minutes are up. You look at the ECG printout, and there it is. Clear, dramatic ST elevation in the anterior leads. The ECG confirms a STEMI. What is your immediate protocol?
Section 4. Reperfusion and treatment. Time is muscle. In the cardiology world, we have a saying, time is muscle. Every single minute that artery stays blocked, irreversible necrosis spreads through the myocardium. We have relentless deadlines we're up against, and for a STEMI, immediate reperfusion is mandatory. This brilliantly illustrates our exact pathways. Our preferred method is primary PCI, percutaneous coronary intervention, essentially going into the cath lab to balloon and stent the artery open. Our target here is a door-to-balloon time of under 90 minutes. However, if you're in a facility where a transfer to a cath lab will delay PCI past 120 minutes, you must pivot immediately to pharmacological fibrinolysis, clot-busting drugs like tenecteplase. Your door-to-needle time target for this is under 30 minutes. Just remember, 12 hours from symptom onset is the maximum effective window for fibrinolysis.
While we're prepping for reperfusion, we have to halt the clotting cascade with immediate medical management. Step 1 is aggressive dual antiplatelet loading. 300 milligrams of chewed aspirin paired with 180 milligrams of ticagrelor or prasugrel, ideally given pre-hospital. Step 2 is systemic anticoagulation, typically using an IV bolus and infusion of unfractionated heparin or subcutaneous enoxaparin. Step 3 are adjunctive therapies, include getting a high-intensity statin on board immediately to stabilize plaques and an early beta blocker to reduce myocardial oxygen demand, but only if the patient is stable and showing no signs of heart failure or pump failure.
Now, I really want to call this out as a massive orange alert clinical pearl, because I need to correct a very common, very dangerous misconception. You might think, the heart is starving for oxygen, let's blast the patient with 100% O2. Do not do this. Hyperoxia can actually cause coronary vasoconstriction, which literally worsens the ischemia. The strict rule is only administer oxygen therapy if the patient's oxygen saturation actually drops below 90%. We've talked a lot about the adrenaline-fueled STEMI protocol, but what if the diagnosis was an NSTEMI? Here we risk stratify the patient. If they're high risk, meaning they have a GRACE score over 140, dynamic changes on their ECG, skyrocketing troponins, or hemodynamic instability, they still need an early invasive strategy, meaning getting to the cath lab within 24 hours. If they're low risk, they can be managed conservatively, often evaluated later with stress testing. Regardless of the risk level, though, NSTEMI patients still receive robust medical management. Dual antiplatelets, anticoagulation, and anti-ischemic meds like beta blockers, nitrates, or calcium channel blockers. So we've navigated the acute crisis, restored the blood flow, and saved the muscle. But the harsh reality of atherosclerosis is that it's a systemic disease. The problem isn't just in that one stented artery. So I'll leave you with this provocative thought as we wrap up today's explainer. Now that we've saved the muscle in the short term, what intense lifestyle, pharmacological, and systemic interventions must we implement on day 2 to prevent the very next plaque from rupturing? That question dictates the patient's long-term survival, and it's a fantastic topic to research for your continued learning. Keep studying hard, and I'll catch you in the next one.